Okay, so good afternoon, everyone. Good evening for some. Welcome to our virtual open house about the AMPATH consortium. I'm really delighted to be chairing this session, and I will introduce our speakers in a moment. But just by way of context, my name is Erica Di Ruggiero, and I am the director of the Center for Global Health within the Dalla School of Public Health at the University of Toronto. We're one of two hubs within the university that participates in the AMPATH consortium, and we're really delighted to have a distinguished lineup of speakers who will share their perspectives about the consortium, what it is, some of the projects that it is involved in, and we look forward to your questions and ideas for how we can further collaboration with the partners within the consortium. So if you haven't already noticed, but in the chat, if you could put your questions there, we will not be taking questions live. And so please do put your ideas in the chat function so that we can then ask each of the speakers to participate and respond in some of the questions. So we have a number of speakers lined up, but before I proceed to introduce them, I would just like to take a moment to acknowledge the land upon which the Lana School of Public Health stands. It is the traditional territories of the Mississauga of the New Credit First Nation, Anishinaabe, Wendat, Huron, and Haudenosaunee Indigenous peoples. It was the subject of the Dish with One Spoon Wombat Belt Treaty, an agreement between the Iroquois Confederacy and the Confederacy of the Ojibwe Allied Nations to peaceably share and care for the resources around the Great Lakes. So as I said before, you can direct your questions to the chat function and provide any comments, and we will have time for a Q&A after we have our panelists. So I will introduce all of them at once. Some of them will be sharing some slides. So our first panelist is Dean Mabel Nangami, who is joining us from Moi University School of Public Health. And we have an MOU that we're delighted to have with the School of Public Health in Eldoret, Kenya. She has over 20 years extensive experience in research and teaching. The next speaker will be Adrian Gardner, who is the Executive Director of the AMPATH Consortium and Associate Dean for Global Health and Director of the Indiana University Center for Global Health. He will then be followed by Kara Wols-Kalustian, and she's the Director of Research for Indiana University Center for Global Health and the North American Co-Director of Research for the AMPATH Consortium, followed by Becky Genberg, who's an Associate Professor at Johns Hopkins Bloomberg School of Public Health, and finally Rachel Spitzer, who is an Associate Professor and Vice Chair, Global Women's Health and Advocacy at the University of Toronto's OBGYN department. So I'm delighted to have all of you join us. And so I will ask Dean Nangami to kick things off and look forward to your remarks.
Okay, thank you very much, Erica. I'm delighted to be part of this AMPATH Open Day at the DL School of Public Health. It's a pleasure to be part of this rich repertoire of speakers. I'm going to make a quick presentation on the School of Public Health. Next slide. In terms of who we are, what we do, and the strategic direction, what is our niche, and what are we looking for in the opportunities that present themselves in terms of partnerships. Next. The context of Moi University School of Public Health is that one of the 4 schools under the College of Health Sciences, which started in 1998. We are a relatively small school with a faculty membership of a complement of 20 faculty members and 3 visiting professors. And I'm proud to mention that amongst the visiting professors, we have 2 from Toronto, University of Toronto, Professor Paula and Ashley. And then we have Wendy from the university, Duke University. Our departments, we have 3 departments. Until recently we had 5, but the harmonization at the university reduced this to 3. So the 20 staff members are spread across the 3 departments. We currently offer 3 programs, 1 undergraduate program and 3 masters, which all have run some of them have run for quite a while, and our graduates are well positioned in various departments or sectors. About 70% of our undergraduates join the government, and another 30% move on to international organizations and private sector, mainly non-governmental organizations, right? In terms of research interest, we have, next slide, please. In terms of research interest, we have, we can roughly divide this into 4 thematic areas. Our full complement of about 20 staff members are thinly spread across these areas. One of the first areas is human nutrition and food security. Being in a developing country, of course, that's a major public health issue and concern. And we are proud that the DL School of Public Health is a great partner in terms of capacity building, a project that Professor Paula is leading, the planetary health module, along with Ashley and other members of the school. We also have research on African indigenous vegetables and how the micronutrients affect the health of school-going children. In health systems block, we have about 6 faculty involved in health systems work, particularly looking at strengthening health systems, but also cross-border health, and looking at building health systems research under global leadership with the Indiana University School of Public Health. We also have the 3rd arm, infectious disease and pandemic preparedness, which at this time with COVID-19, obviously, it's a very important thematic area of our research. Previously, we are focused on malaria, the epidemiology of malaria, working with Professor Wendy and her team in western part of the country, and also looking at supporting diagnostic and testing facilities by establishing laboratories. We also have worked with the East Africa community in setting up pandemic preparedness, capacity building for disaster planning and response. And our flagship Master of Science program and field epidemiology, all the fellows under that program are currently deployed in the COVID surveillance and contact tracing with the Ministry of Health. We also have a project that is looking at COVID and dietary diversity amongst those who recover. The last arm, which we plan to really expand, is the non-communicable diseases. We're looking at indoor pollution and how that affects, of course, respiratory problems. But we have some studies focusing on cancer of the esophagus, and also sickle cell disease, which is predominantly in western part of and coastal part of the country. These research areas attract different sponsors or funders, but we are glad that amongst those we have NIH and most of our partner institutions supporting us. Next slide. So what is our strategic direction as a School of Public Health? We would love to be a global center of excellence in training, research, practice, and service in areas of public health and health system strengthening. Our mission, how to get there, we want to be a research-rich, research-driven type of training, using multidisciplinary approach in training our health professionals. And as such, most of our programs are multidisciplinary. We engage different disciplines from during application and also the learning process. Our core objectives as a school are in 4 parts. The first is the training, which of course as an academic institution, we try to promote quality training, not just working with our regulator in Kenya, but also international accrediting bodies and also the professional bodies for the various professionals who come to us. More importantly, we engage communities in our training. As a public health school, we love to work with households and communities also during our placement as we learn. The second pillar of our strategy is the research. And our research, we try to ensure that we not only focus on priorities at national and international level, affecting the continent, but we try to promote research that informs policy and practice. The third area, we recognize that public health and health in general is a right. So we try to mainstream the rights approach by ensuring that whatever we do in terms of service delivery, we ensure it's the right service that is delivered to the right client or customer at the right time, right place, at the right price, which is a major challenge in our region, and also in right condition in terms of drugs and supplies. We also weave in the governance issues, which at times challenge us, but it's our school that is partially responsible in supporting the government to ensure that we do this in a transparent and respectful manner. Particularly if you look at the deaths with COVID patients, the way the barriers have been conducted, it's an area of interest. The last area is building sustainability. By working with partnerships, strategic partnerships and networks. And not only that, but we also want to ensure that our students and the alumni are part of that partnership and network. Next slide, please. Our strategic direction in terms of our niche, we use the SPICES model as our philosophy, which anchors us in student-centered learning, lifelong learning, working through small tutorial groups to build the team approach that we expect of public health disciplinary professions. But we cannot do this just as a philosophy. So we plan to enhance our niche by establishing centers of excellence. We are in the process of trying to set up one for health system strengthening using primary care approach for UHC, but we are also keen to support a center of excellence for global health and infectious disease. Similarly, we want to grow this niche by starting new programs, and because of COVID-19 now we plan that most of them should be online, and our focus will be PhD programs amongst those listed on that slide. Next, please. Lastly, in terms of looking at our partners, our mapping for this presentation, our AMPATH partners are in 4 areas. We have the University of Toronto, the Dalla Lana School of Public Health, we have the Duke Global Health Institute, and we have the Indiana Fairbanks School of Public Health, but along with many others, including School of Medicine at IUPUI. And then lastly, we have Johns Hopkins University School of Public Health, the Bloomberg School of Public Health. These partners have strengthened our position, and we would love to find opportunity to continue to grow these positions, strategic interests of mutual benefit to both institutions and countries. We are proud that the Dalla Lana School of Public Health is supporting us with a planetary health course in capacity building. And next week, we are having a school meeting where we are going to mainstream planetary health as a course in all our curricula. We also are proud that members of the school are visiting professors, Professor Paula and Ashley, and they are also strongly engaged in the AMPATH public health and primary care working group. Similarly, all the other groups, including Duke, we have initiatives which involve capacity building and research, and I've visited Duke University, and also we want their support to set up the Center of Excellence. Similarly, I recently visited Indiana, and we have very many ideas on how we can grow our partnership, and we are working on preparing strategic direction. And similarly for the Johns Hopkins Bloomberg School of Public Health, we are proud that we are writing a generic grant, and we hope to grow the partnership from what we have done so far so that we can include student exchange and staff membership. Lastly, I would say there are, yes, many opportunities that are before us, and we would love to note that AMPATH in itself as a consortium has presented a great supportive environment and legal environment with the RSPA office for us to challenge ourselves in writing grants and growing these partnerships. We also recognize that county governments, we have a devolved health system, are important to us if we are to build in sustainability. But we also, as a School of Public Health, want to reach out to the private sector to have the PPP function well. We can't just rely on the public and partners, but we want to reach out through philanthropy and others within our country. COVID-19 presents unique opportunities, and we want to seize on this to be able to advance our agenda in public health and also leverage the strengths of networks. Africa has a dearth of networks. Beyond AMPATH, the Public Health and Primary Care Working Group, we also have CDC Africa, we have the Africa on One Health Universities Network, we have the Association of Public Health Schools in Africa, and many others that we want to have a buy-in so that we can grow our niche as partners. And technology is important for us to innovate. And lastly, we do love that we can have help from our partners to trace our alumni so that they can become a strong lobby group and partner for the School of Public Health. Thank you very much for this opportunity. I look forward to growing our partnership for mutual interest of our communities in areas of public health and health system strengthening. Asante sana. Thank you.
Yeah. Well, asante sana, Dean Nagami. Thank you very much for that excellent overview. Just for those of you who've joined a bit late, I'm going to ask each of the presenters to present, but in the meantime, please put your questions in the chat as they occur to you. So I'll turn next to Adrian.
Thanks, Erica. And thank you all. Good afternoon, everyone. And thank you all for the opportunity to be here. The slides here. So I'm going to try and take just 5 or 7 minutes to try and give you a brief history of AMPATH and sort of highlight the principles of our partnership, which is no small task in 5 minutes, but we'll try. Next slide, please. So AMPATH stands for the Academic Model Providing Access to Healthcare. And it's really a partnership between Moi Teaching and Referral Hospital, Moi University, and a group of North American institutions that's led by Indiana University, but now made up of 12 North American institutions that have partnered with these 2 Kenyan institutions. And the partnership began in 1988 when Moi University first started really its medical school. So it was the second medical school in Kenya. And Indiana has had full-time faculty on the ground since that time in partnership, and slowly over time that partnership has grown to include a number of different North American institutions. Next slide. So before we get to I'll show you a slide of all the North American institutions, but I wanted to highlight some of the principles of our partnership because I think they're somewhat unique in the sense that, or at least they were 30 years ago when this partnership started, and I think they've held us well over the years. So essentially the partnership was built on a philosophy of being inherent power and responsibility of a public academic health center. And that power had been relatively untapped within the African setting. And yet we've seen examples around the world of academic health centers working with public hospitals, particularly those that serve the underserved populations, as a way of improving the access to care and the quality of the care that those populations receive. So the number of sort of implications from this tagline, our program is Kenyan-led, and we try to be very responsive to the needs of the population. So this is really a long-term engagement. It's not built around a single grant or a single source of funding with a 5-year term, or it's really seeking to build and support an academic health center that's responsive to the needs of the population that it serves. And so by definition, the population is the denominator in many ways. And so we take a fairly broad definition of health that's inclusive of social determinants of health and have a number of programs that address economic well-being as well as some traditional health outcomes. We see ourselves in some ways as an innovative engine for the Ministry of Health in partnership with the county and the national governments. Increasingly in Kenya, there are a system of devolved government. There are 47 counties. Each one with a governor and a parliament, and health in particular is devolved really fully to the county level, with the exception of a national policy body at the national level. So again, the AMPATH partnership, it's not, it was really a genuine effort to try and create a care system that hosts and enables training and research. So again, leading with care, but recognizing ultimately that all three missions of an academic health center are really critical to the long-term sustainability. And I think perhaps more than anything else that we're proud of, I would say we've built a partnership that's resilient, that's able to make mistakes and self-correct, that again does not fall apart as soon as one thing goes wrong. And obviously we're being challenged a little bit now with the global pandemic, and as all global health programs are, but I have confidence that we will overcome this one as well. So next slide, please. So one of the principles we have is really a very deliberate effort to organize the North American effort. So unlike many partnerships in Sub-Saharan Africa and other places in the world in global health partnerships, we have tried very much to sort of organize the North Americans in such a way that we're all working in a complementary relationship under one leadership. And so the way we operationalize that is we have institutions join with a particular anchor area, and expect those institutions and those faculty from those institutions to lead across the tripartite mission in care, training, research, which does not preclude other North Americans from other institutions from joining those efforts, but they're sort of led and directed by that North American, obviously in conjunction with their Kenyan counterparts. So the counterpart relationship is really fundamental to the way that all of us are engaged in Kenya. But we have both, we ask institutions to make both an institutional commitment, and of course there's a very strong personal commitment from a number of different faculty that have engaged over the years. Next slide. So we seek equity in the partnership, right? So ultimately we recognize that there has to be mutual institutional gain. North American institutions have to gain from this. The Kenyan institutions have to gain from this. So that's, again, operationalized in a bilateral medical exchange of faculty and trainees. So each North American institution that is part of the consortium agrees to host Kenyan trainees as part of their, part of the consortium. We've very much tried to create research opportunities for both Kenyans and North American faculty and junior faculty, especially as they come up. And I think we all recognize that there are opportunities for reciprocal innovation. So there's creative space in Kenya to develop health systems and learn lessons from that are applicable certainly in our settings as well. And so that's a recognized sort of benefit from the program. Next slide. So very briefly, and it's a tremendous oversimplification, but just a brief history of our care program, as I alluded to, started really in the late 1980s when Bob Einherz served as the first team leader, and really started as a bilateral exchange of faculty and trainees, strong emphasis on faculty development, and the establishment of the Research and Sponsored Projects Office that I'm sure Dr. Wolf-Galustian will discuss. But and that really characterized the program for the first 10 or 12 years. And then in 2001, we realized that we had built this nice academic collaboration in the middle of the HIV pandemic, and again, felt an obligation to respond to that need in the community, as what's now sort of characterized what I was describing before, that leading with care mentality. And so we started treating our first HIV patients, and leveraged the existing relationships that Moi University had with this community health centers to establish and bring up HIV care centers throughout Western Kenya. In 2004, we received our first support from the President's Emergency Plan for AIDS Relief. So that's the US government support for HIV services in 22 high burden countries. And we've had sustainable funding from them for since that time. So we now care for about 160,000 HIV patients, all within a Ministry of Health framework and Ministry of Health facilities, but across 10 counties in Western Kenya. So because of this institutional relationship, we were able to rapidly scale up the delivery of HIV services because it was built on a foundation of trust between individuals and institutions. And I would say really over the last 10 to 12 years, we've returned in some ways to the original mission, which was much more of a health system strengthening agenda, not necessarily an HIV silo, but tried to leverage the funding for HIV and the infrastructure built by PEPFAR to bring in other sources of funding that support maternal child health care and chronic disease care, and again, recognizing the social and economic determinants of health. Next slide. So that's Bob Einherz and his family back in the 1980s. So this is our current consortium. So there are, again, 12 North American institutions that are part of this. And we've all found a way to play nicely in the sandbox and have developed some SOPs that allow us to work effectively and efficiently and not step on each other's toes. And really, an explicit goal was to not create a huge burden on our Kenyan colleagues to manage multiple competing interests. And so I think we've, one of the success stories that we found a way to do that in a fairly nice way. Last two slides, I'll just say, to give you a sense of the current care and education portfolio. And I'm sure, again, Kara, I've got a slide on the research as well, but so the current AMPATH Plus funding is about $25 million annually. So that's the PEPFAR HIV support. We have another $7 to $8 million of other care funding, largely from foundations and corporate partners. Training grants, about $3 million, and cumulative research funding over the 30 years is about $146 million. So significant portfolio. I think there are currently about 140 projects that are managed by the Research and Sponsored Projects Office. So this is a map just to show you essentially the AMPATH catchment area. Obviously, we have various different programs going on in different geographies, but gives you a sense of where we're located. And then the last slide, really, a lot of this Dean Nangame has covered. Just to point out some opportunities that I see for further engagement in public health. Dean Nangame has really elucidated this nice plan for engaging with county health leadership in the context of devolution. I think that's a real need in Kenya to develop leadership skills and across the board, from ethics and supply chain management, using data to guide health decisions. Part of our effort has been an electronic medical record system for HIV that's increasingly being used for other chronic diseases. And yet really that data is not utilized in the way it could be for decision making at the county level. There are a lot of health promotion interventions, and again, our broad sort of population health and universal health cover effort right now is inclusive of a number of different areas. So I'll stop there because I don't want to go over too much time. Thanks.
That's great. Thanks so much, Adrian, for that succinct overview of I know, a very long and distinguished history of AMPATH, and look forward to hearing people's thoughts about the opportunities for collaboration. So we're going to switch gears, and I'm going to turn it over to Kara now to talk a little bit more about the research programs, and then over to Becky and Rachel.
Hi, so while the slides are coming up, I'm Kara Wolfs-Kalusti, and I've been part of the AMPATH program since before it was AMPATH, so about 30 years now. Next slide. So really, we're in AMPATH, our research mission is guided by the principle of leading with care. We work in partnership to develop local research talent to identify, develop, disseminate relevant and timely information to improve the health of underserved populations. And truly, this is embedded in the knowledge that social determinants of health may be far more important than care systems or care delivery. Next slide. And we really wish to be a vibrant, world-class, Kenyan-led community of researchers engaged in continuous improvement of health globally. Next slide. We are structured with two directors. Professor Nandiko is the Kenyan co-lead for the AMPATH Consortium research program. I am the North American co-lead. We actually have 3 co-field directors. The slide has not been updated. Wende O'Mara has moved on from her co-field director position. We have a number of working groups, and these really are geared towards improving collaboration, reviewing protocols to ensure that we don't have overlapping conflict, nurturing junior investigators. We are in the process of trying to evolve our working groups to be more functional in an environment where numerous people have competing goals and opportunities and time commitments. And so we're in the process of restructuring those. In the midst of this, cores really support the work we do. So the laboratory is a core, operations is a core. The research office provides support as far as information about how to institute or engage in a research project there. And then we have evolving working groups in process. Next slide. So just to go back to the beginnings of our research program, when we started providing HIV care in 2001, our primary questions centered around how to provide a chronic care model within an episodic care structure. And so a lot of our questions simply revolved around how to take care of patients for long periods of time in a healthcare system that was really designed to deal with acute illnesses, acute injuries, perinatal care, those types of things. Next slide. We had dozens of questions, including how to deliver care when the roads are no longer passable and you can't get people their antiretrovirals. Next slide. And this has led to a number of programs that have grown out of this over the last 19 years. Next slide. From the Moi Clinical Trials Unit that is now completely Kenyan-led, that does clinical trials on drugs and interventions for predominantly HIV patients, that started out with US funding through our AIDS Clinical Trials Unit, but now has funding through the UK MRC, the European Africa Research Network. Next slide. To multinational programs for which AMPATH is the flagship program. East Africa IDEA is part of a global consortium with 7 regions funded by NIH to look at the rollout of HIV care and treatment globally and to look at those outcomes. The word salad tells you what we do work in. I won't go into details, but it's a very vigorous and the largest HIV cohort globally. Move on. The Global Network for Women's and Children's Research looks at issues related to maternal child mortality and improving health outcomes. Next slide. The U54 Oncology Institute works on issues related to cervical cancer prevention and optimization of treatment. Next slide. Traumas for Change is really a population health initiative that houses various research projects. Next slide. This is a very interesting and unique initiative that empowers women to care for their children as well as developing financial independence. Next slide. We have continued to be highly successful in obtaining grant funding. Next slide. And highly successful in our publication record. Next slide. What we have learned over the last 19 years, over the last 3 or 4 years, has turned into the concept of reciprocal innovation. Some of you may have heard the concept of reverse innovation, which brings innovations that have been developed in low and middle income countries back to the United States. We are more invested in a continuous evolution of innovation that requires a constant dialogue between ourselves in North American high-income countries with those in lower-income countries and adaptation of new innovations for the setting that are required. And we're moving this concept forward over the next several years. Next slide. So we are, of course, sponsored by a number of people and have been over the years. Next slide. But mostly, I would like to thank all our patients and all the people who have worked together to make this program successful.
Great, thanks very much, Kara, for that overview of some of the research exemplars of AMPATH. So Becky, I think we're going to turn to you next. And then just as a reminder for those of you who've joined, if you could put your questions in the chat. I've started to take note of the ones that have already been registered. Becky?
Thanks, Erica. Hi, everyone. My name is Becky Jenberg, and I'm here representing one AMPATH initiative and another School of Public Health. Just to give an example potentially and to open up for potential future collaboration with another School of Public Health and faculty from across the consortium focused on public health research. And so I represent both Johns Hopkins as a partner in the consortium, as well as a large group of folks working within AMPATH focused on population health. So I think Adrian mentioned this in passing, and Dean Ngami as well. Population health is a partnership that was established between AMPATH and the Ministry of Health to really focus on integrating vertical programs into a more comprehensive system of care. At the same time, acknowledging and strengthening some of the initiatives across the consortium that focus on the social determinants of health. The long-term goal of the population health program is to achieve universal health coverage and improve health and wealth for the entire AMPATH catchment area. So Hopkins, as a partner in the consortium, joined with the intent of really helping to bolster some of the monitoring and evaluation efforts that go along with the AMPATH population health program. So I want to give just some insights into potential areas in which we could extend our partnership out and include some folks at the University of Toronto as well. So how does the AMPATH population health program operate? Well, it's has three main strategies or pillars, and these pillars include empowering community economic strengths, and this is mostly through the support of existing and the creation of new groups within the community that are focused on income generation and economic strengthening in the household through agribusiness, local savings and loans, and table banking within the community, as well as focused efforts on improving financial literacy, as well as food production and other aspects related to nutrition. The second pillar of AMPATH's population health program is really meant to create a seamless and integrated care system. So taking these vertical programs and really integrating them in a real primary care approach. And a focus there is on, again, thinking, as Adrian mentioned, the denominator here is the population, and how do we really have an impact across an entire population. And this is all supported using AMPATH's robust electronic medical record system. The third pillar is really to focus on the financial aspects of providing healthcare, and it's ensuring universal health insurance coverage. And this is meant to be an effort in which all families and households living within the catchment area are provided with this coverage through the NHIF, which is delivered from the national level. And so these three pillars sort of work in concert together, empowering communities' economic strengths to access healthcare from a seamlessly integrated system. Next slide. So that's a lot of really large, broad scale concepts, and really it presents a challenge in terms of how we measure the impact of these various initiatives at the population health level. Across AMPATH, these individual pillars did grow up sort of as separate programs, and now, of course, integrating them requires us to think about how to monitor and evaluate them within a consolidated framework. So how do we synthesize information from across these three pillars to really get a sense of the impact of this program, thinking about the indicators we would use to measure success, the data systems that are in place to capture information from each of the pillars, how the data flows across the system, and of course the funding streams. These are all at the moment three separate programs, if you will, which are being integrated into one. And so how do we as a monitoring and evaluation program really think about the impact of these three pillars overall across the population? The challenge too is that there are limited population-based data sets with which we can work with to measure the impact of this program at the population level. There is DHS data in Kenya, which has gone through maybe 5 or 6 or 7 cycles over time. This doesn't really give you that disaggregated data more at the community level, so it's kind of limited in its use for evaluating a specific program which is delivered here across Western Kenya. We do have some initial baseline data that was collected by AMPATH within one sub-county, but really the goal is to kind of think about how to assess the impact of this program without having that baseline data in place and without having potentially disaggregated data with which we can see the changes in some indicators over time. Of course, the last challenge is in any public health program, but in this context in particular, there's a lack of a consistent and reliable national ID with which to reliably identify patients across the health system, as well as people in the community, with which we could use to measure the impact of interventions and the initiatives over time. And so that just creates a set of challenges within which we're working to really demonstrate the impact of this model. Next slide. So as a starting point here, we've drawn on the Primary Healthcare Performance Initiative conceptual framework with which to guide us in terms of which kinds of indicators we would like to move towards measuring. And you can see these represent different levels. So the system level inputs, service delivery, outputs, as well as outcomes. And the goal is really to capture and measure information across all of these different levels. Next slide. So here's just some examples of the different types of indicators that we are working toward measuring. And the goal, again, is to really be able to demonstrate the impact of this initiative at the population level. So next slide. You can see just examples from across the different levels from the conceptual framework, from the primary healthcare conceptual framework. Next slide. And so next steps, really our goal is to develop and implement some low cost and cutting edge methods to measure these population-based indicators, the coverage of key practices and interventions, as well as population health outcomes, which would include mortality rates across the AMPATH communities at both the county and the sub-county level. I think the key components which were really re-emphasized during the 40th anniversary of the Alma Ata 1978 declaration, emphasizing the importance of primary care, are really to empower and involve local communities in the data collection, as well as to strengthen the coordination and the data use across the counties and the sub-county level. So we've been working really closely with the Moi School of Public Health, as well as within the county and the sub-county level, to come up with a system that can be comprehensive and sustainable over time. Thanks.
That's great. Thanks, Becky. I'm sure there'll be lots of interest in this particular topic, since in Toronto we certainly think a lot about primary care and the interface with other parts of the healthcare system. So Rachel, I'll turn things over to you, and I've been taking note of the questions that have been coming in. So after Rachel's remarks, we'll turn to the Q&A.
Sure, and knowing that I was going to be what stood between everybody and the opportunity to ask some questions and answers, which I really think is probably the heart of what people want to get at, on top of the framework that's been provided in such a wonderful way by all of the speakers. I didn't put together any slides, and I'll keep my remarks quite brief. I'm an obstetrician and gynecologist at the University of Toronto. I represent an ongoing collaboration between our Department of Obstetrics and Gynaecology and the Faculty of Medicine and AMPATH since 2007, which is when the University of Toronto joined. And if we look back, our work in reproductive health and what was at the time the Center for International Health as part of a School of Public Health, which is now a larger center in the Faculty of Public Health, stretches back those 13 years. As Adrian described, we really do try to fulfill and leverage the academic mission as a tripartite mission of clinical care, research, and education. We've been involved in all those areas in the consortium. Clinically, really since 2007, most of that time we've had faculty or junior faculty working on the ground, providing clinical care alongside our Kenyan colleagues, working in a similar model to the rest of the clinical departments within AMPATH, using what's called as a team leader or junior faculty on the ground as sort of the basis for our local face of the collaboration, if you will. We've worked in all general areas of reproductive health and obstetrics and gynecology. And I would say that some of the exciting areas that are ongoing at the moment include some foray into adolescent health, adolescent pregnancy care, and some of our more novel research grants. And I think some of the opportunities that we look to focus on in particular as we build our relationships to locally in Toronto with the Faculty of Public Health would be focused in those areas. Our research has typically been based on our clinical outcomes and to prove the value of our clinical programs. And again, you've heard some of that. The CHAMA's program around maternal health and care would be but one excellent example of those. We do have a working group in reproductive health and research, which is joint with our clinical group, where we discuss those items. And there are opportunities for trainees to work in research within the AMPATH program, both for some of our clinical junior medical trainees. There are, over the years, some grant opportunities that bring medical students to Kenya when there's not COVID to work in research care in their more junior years, and also greater opportunity for involvement of all of our long-term clinical care providers, team leaders, research staff, you name it. And there is a mighty office of research staff engaged on the Kenyan side, helping to run our projects and administer our grants. We've had collaboration likewise in these areas with the Faculty of Public Health around MPH students and practicums, and some opportunities that we're looking forward to developing for longer term collaboration there as well. Our educational offerings, as Adrian described, we do participate in all bi-directional electives for medical students from both sides of the consortium, for registrars and residents from both sides of the consortium. And in the 13 years that we've been working together, our colleagues in Kenya in reproductive health have started what we would call here residency or registrarship in reproductive health that did not exist in 2007 when we started a 4-year training program in obstetrics and gynecology. And we've worked together with our Kenyan colleagues to start 2 fellowships locally in Kenya, 2-year programs to train the country's first gynecologic oncologist. That's now been going on for about 5 to 6 years, and graduating the first gynecologic oncologists in the country, who are now working throughout Kenya and the region of East Africa, and also for the past 1.5 years starting to train high-risk obstetricians or maternal fetal medicine colleagues, who we look forward to doing the same and adding to the capacity for high-risk obstetric care. We've also developed a fellowship program through the University of Toronto to train graduated OBGYNs in global health, with both care of underserved populations here in Toronto and feeding into the team leader position in Kenya. And I think I'll leave my remarks at that to open the floor for opportunity for questions.
That's great. Thanks very much, Rachel, and thanks to all our panelists. So I've been taking note of some of the questions. I'm going to start with a question that came in very early to Dean Nangami. So on your slide, you made reference to technology and information driven. I'm not sure if we can go back to your slide to give you some context for that. But the question had to do with what did you mean by that, and if you could elaborate. And the question's coming from someone who has a health informatics background, so was very interested in knowing a little bit more about your technology and information-driven approach. Yes. Thanks,
Okay.
Ophelia. Yeah, it's maybe just go back to the other slide, Ophelia. I think you skipped over it. It was.
Thank you very much, Erica. What I meant is that we have several things that are going on. We know that within the context of a devolved health system, we have, as Adrian mentioned, 47 county governments, and each one of them is competing for the best information, best practice, so that they can model their own context-specific interventions. So we acknowledge that there is technology, and we have seen this piecemeal demonstrated in various interventions, including AMPATH, where we've seen tremendous, very good innovations working with community health workers and so on. But as fellow panelists have put it, all this is like piecemeal information, different projects doing something, and within the country, there's different entities and agencies doing research in different things, how to use technology and community health workers, and what can you leverage, what can't you. So you'll have one working with cancer, another one working with something different, another one working with just reproductive health and so on. So the challenge and the opportunity is we do have the technology, but we need to see how we put it together so that we can really leverage the strength of what we have. For example, Adrian mentioned the electronic medical records. That is a very good model which the Ministry of Health has had buy-in. But when you look at the broader scope, counties are still struggling with how to then access the data, analyze that data, and use it at the point of collection so that they can inform decisions and policies and practice. So why I put that as a key challenge and yet an opportunity is that the School of Public Health is in a unique position to try and bring together. We do have an institute of medical bioinformatics within the College of Health Sciences. We do have what AMPATH has been doing. So we want to see how we can put it together and build the capacity of counties, particularly the research units. Under the devolved government, each county is supposed to have a research unit or a research department. So those are grossly understaffed. Some of them don't even have staff, and they rely on partners like us, like AMPATH, to come in and try and give support. So that's what I meant, that we need to have that, and the School of Public Health is in a unique position to try and leverage that technology and have information-driven innovations to scale.
Great. Thank you so much for that answer. And I would invite the person who asked the question to ask any follow-ups. Maybe because you did mention EMR, there was a question actually directed to you, Becky, to maybe just expand a little bit on the EMR, and others can feel free to tag on. And then the other question I'll ask, because it's directed at all the panels. So panelists, if you want to give some thought to what might be an example of a reverse innovation that AMPATH helped to support. So I'll give you a heads up for the rest of you to maybe think of an example. So Becky, maybe I can turn to you first to answer or expand on the question about the EMR and that you use, and to think a little bit more about that. That's all I have in terms of the question.
Sure. I know that others present today can probably speak more to this than I can. But AMPATH uses the AMPATH Medical Records System, which is a platform that was developed from OpenMRS and developed in the early years of AMPATH by the Regenstrief Institute. And it is now expanded to include portable data collection. So clinicians do use tablets at the point of care delivery, in which they are collecting data, clinical data from patients during encounters, and that gets stored within the medical record system. I don't know if Adrian or Kara, if or Paula, anything you might want to add to that.
Anyone else want to add, tag on?
I think that's a great summary. Yeah, so Partners in Health and Regan Street helped develop OpenMRS, which is now used as a data platform for, started out being used as a data platform for HIV care that's been replicated in many places and is now taking over as countrywide EMRs in some countries. So it now supports the HIV care system in Uganda, Kenya, and Rwanda, and other care functions.
Thanks. Adrian, maybe can I turn the next question to you, because I think it was triggered by your slide around reverse innovation, but others may have some ideas. What's a good example of a reverse innovation that might have been catalyzed through the AMPATH consortium?
Sure. So I think there are a number of examples, and I'm sure Kara can comment as well. But one that comes to mind is a program in Indiana that we call We Care, which is led by Dr. Deb Litzelman, but it's really an effort to leverage really a community health worker model to deliver supportive services to women who are at high risk of poor outcomes of pregnancy, and to essentially accompany them through the sort of, help them navigate the health system and overcome some of those social determinants that end up resulting in poor outcomes, either maternal or child outcomes. And so it's particularly focused on the African American community in Indianapolis, in the Indianapolis area.
Thanks. So Kara, did you have another example of reverse innovation?
No, but to refine that again, we don't really like the term reverse innovation. We are embracing the idea of reciprocal innovation. So things that have been learned, that program has gone back to the Chamas for Change program within Kenya. And some of the innovations made with Chamas for Change about tabletop banking and those types of things, they're now trying to adapt within the We Care Indiana program to help foster economic independence to women who are involved in that program. So that's the reciprocal nature of things, is that innovation goes in both directions, that things that are learned are brought back. To give you another example, though, Kenya, or actually Sub-Saharan Africa, has a counterfeit drug problem. So depending on what drug for treatment, up to 30 to 60% of the drug might be counterfeit. So Purdue University developed an easy card system that could be used to you run a tablet, or you put the liquid onto the card, and it helps determine whether or not there are counterfeit components or the complete drug is counterfeit. So that was tested and implemented in Sub-Saharan Africa, and then has been brought back to the United States for use by law enforcement to determine whether or not illicit drugs are actually what they think they are, or whether they've been spiked. It helps in dealing with overdose situations and situations where there's a toxic reaction. So that's another of the sort of reciprocal innovation.
Yeah, thank you. So the next question I have, and maybe this is for a number of you. So the question is that, looking at the consortium, Moi University is the only Kenyan partner, and the participant was wondering if there'd been any interest from other Kenyan institutions to join AMPATH. Anyone have comments on that or thoughts?
Other Kenyan institutions?
Yes, that's right. Yeah.
I mean, there have been some discussions around, Moi being the second medical school in Kenya. I think there have been a number of other medical schools that have come up, and many that have been led by graduates of Moi University, and so are familiar with the AMPATH model of partnership, and have tried to replicate to varying degrees the sort of institutional partnership. And they're, I would say they're still sort of young in their collaboration. I don't think they've sort of taken off in you know, well, they're young, right? We've been at this for 30 years, and so we've come a long way. We're also, I should maybe take the opportunity to mention that we are sort of replicating the AMPATH model of partnership in 2 other countries, so in Ghana and in Mexico. And there'll be institutions within our consortium, they'll be the primary leads of those efforts in northern Ghana, so NYU, New York University, and the University of Development Studies in Tamale, and University of Austin, University of Texas, Austin, sorry, in Mexico. And so those are just at the beginning of those replication efforts, but trying to take those same principles and apply them to a new geography and see what can come out of those.
Okay, that's good to know, actually, because I think maybe some of the same partners who are around this table also have connections to those different regions as well. We're starting to run out of time, so I have, maybe I'll just take the opportunity to ask one more question. And that is, do the innovations in data systems also intersect with other programs being implemented? For example, some of the reproductive health programs. So in other words, the data systems that you're putting in place, are they being used to, I guess, measure the impact of some of the programs? I don't know who wants to speak to that, Kara or Becky or maybe Paula.
Or maybe Rachel, since she's.
Or maybe Rachel. Or whoever wants to take the question. It's a fly ball at the moment.
I mean, I can just say that systems like the OpenMRS and the REDCap data systems and things like that certainly extend across the patients. If you're looking at OpenMRS, for example, as a patient care program, if you had somebody who was an HIV patient and receiving care in the HIV module of the program, that would be available in OpenMRS. If they then intersected with another area of the care program for pregnancy, there would be other data points that would be in there from their pregnancy. So from that perspective, it's sort of like there are fluid EMR opportunities. Certain research data may be kept in certain different databases or extracted for use in that way. I'm not sure if that answers the question, but that's how I understood it.
Okay, thanks. So in the interest of time, I'm going to wrap things up, but what we'll do for the questions we didn't get to, we will follow up with you and consult the panelists, but I just want to take this opportunity to thank all our panelists for joining for a very informative session. And we would encourage all participants to send any ideas for collaboration, since we have run out of time to get some suggestions, but I think we've started to see the discussion. So thanks to all of you for joining at the various times of the day and evening. We're very appreciative of your contributions, and thanks so much. And thanks to all participants for joining.